Hi, thanks for joining us here today for the topic of cases from which I learned in genitourinary pathology. I'm Sean Williamson, and I'll kick off with a couple of cases that I learned from in GU pathology. Sort of for most of these, the theme is that I encountered an index case which I thought was challenging for some reason. And then actually, for most of them, did some kind of spun off into a project that helped me better understand these lesions. So for the first one, this is a 45-year-old woman who had a prior hysterectomy, but really nothing prior in terms of bladder neoplasia. And she underwent transurethral resection of a bladder mass. And so here we can see this sort of bland spindle cell proliferation with some kind of edematous stroma. And then at the bottom, there are some more typical bladder smooth muscle of the wall in the lower right-hand corner. Going around to some different areas, again, this spindle cell proliferation is sort of bland with some edema in between the tumor cells. And then even if you look at high magnification, there are almost these kind of microcystic spaces with some edema, but again, very bland cytology. Using some immunohistochemistry, we see here that there's positivity for keratin in kind of a delicate linear pattern labeling the spindle-shaped cells. Smooth muscle actin, substantial labeling, and you might kind of be able to visualize some of the so-called tram track pattern that we expect of myofibroblastic proliferations, where there's kind of parallel lines within the cytoplasm. A lot of staining for desmin as well. However, this particular one had negative staining for caldesmin, so sort of arguing that it's not an actual smooth muscle tumor since it's not positive for both of those smooth muscle markers. And then if you're thinking this might represent an inflammatory myofibroblastic tumor, we did immunohistochemistry for ALK, which showed a negative result. We usually use the D5 F3 clone, which is thought to be very sensitive, and so if it shows a negative result, there's unlikely to be ALK rearrangement. So what do we do with lesions like this? I sort of refer to these as a pseudosarcomatous myofibroblastic proliferation, but various names have been used for this type of lesion throughout papers over the years. Another one is postoperative spindle cell nodule, especially when we're talking about the setting of a previous biopsy, a previous transurethral resection or biopsy that thought to be perhaps exuberant reactive myofibroblastic proliferation in response to the trauma of a previous biopsy. Another term that's been used is a fibromyxoid pseudotumor. And so I guess historically we've kind of assumed that this represents a kind of exuberant reactive process. When you have a spindle cell lesion in the bladder, I think you should always consider sarcomatoid carcinoma, especially when you're talking about a elderly male patient. Now, in this particular case, we have a relatively young woman, so which is somewhat atypical, but not impossible for bladder cancer. And then looking at the immunohistochemistry, actually, that diffuse uniform keratin staining that I mentioned, I kind of expect minimal keratin staining in sarcomatoid carcinomas, and we'll show an example of that in a minute. In this particular one, also, we did several urothelial markers, which were negative, arguing against this representing sarcomatoid urothelial carcinoma. But here's one where I think there's at least a little bit of similarity to the current patient, where there's some edema between the tumor cells and spindle-shaped configuration of the cells, but maybe you can make out that there's a bit more cytologic atypia. And then, of course, in this other example, we have actual carcinoma admixed, which makes it more obvious that we're dealing with a sarcomatoid carcinoma. And here at high magnification, just to show that there is some similarity in the morphology, but at least a little bit more prominent cytologic atypia in this one. And as I mentioned, in this particular one, keratin was difficult to demonstrate any evidence of epithelial differentiation with immunohistochemistry, so keratin was negative in this one. Although you can make out a little bit of staining for GATA3. Of course, it labels the epithelial component in the upper right. And looking at the spindle cells, it can always be difficult to tell whether GATA3 is labeling T lymphocytes in the background or whether it's labeling the actual spindle-shaped cells, but it looks like at least some of the larger cells are labeling. Similarly, for P63, there's some labeling of some cells in the background there. And I always like to refer to this study by Drs. Joe and Fletcher, which suggested that it's pretty rare to have P63 positivity in actual soft tissue type tumors. And so in most cases, that would argue for a sarcomatoid carcinoma with some specific exceptions, like, for example, myoepithelial tumors. So some immunohistochemistry that could help you in distinguishing sarcomatoid carcinoma from myofibroblastic proliferations. I've highlighted in yellow the ones that would differ between sarcomatoid carcinoma and myofibroblastic proliferations. The other ones could have some overlap, like smooth muscle actin could have some positivity in both, or pankeratin could have positivity in both. But if you use multiple urothelial type markers like P63 or high molecular weight keratin or GATA3, hopefully between them you can get at least one or two positive to support a sarcomatoid carcinoma. And here was another study where they looked at spindle cell lesions of the bladder specifically and compared myofibroblastic proliferations and sarcomatoid carcinomas. And again, I highlighted in yellow the ones there that were differential between the two. So there was no high molecular weight keratin or P63 in the myofibroblastic proliferations. And there was some in sarcomatoid carcinomas, although this one showed actually a lower percentage of positivity than the previous one that I just showed. Thinking of spindle cell lesions in the bladder, another thing that you could consider is leiomyoma. Typically, a leiomyoma would have more obvious eosinophilic cytoplasm, like you can see here. And actually, it can be difficult to tell whether you're dealing with a leiomyoma or just the normal muscularis propria of the bladder. In this one, hopefully you can make out that the leiomyoma at the left has a bit more of sort of a swirling haphazard architecture, whereas the normal smooth muscle of the wall is more bundled into discrete packets of smooth muscle. And in this one, Cal-Desmin is positive both in the normal muscle and in the smooth muscle, in the leiomyoma. So we're talking about myofibroblastic proliferations of the bladder. What's the distinction between those and inflammatory myofibroblastic tumor, or IMT? I think the distinction between those two is kind of blurry, and some would perhaps lump them all together into one. Interestingly, one study earlier found that although sometimes there was ALK positivity in these myofibroblastic proliferations, the ALK fish was negative. However, I'll show a more recent study which might explain what's going on with the ALK situation in the bladder. So this recent paper from the Brigham group suggested that when you have IMT, myofibroblastic tumors in the bladder, most of the time the fusion is between ALK and another gene called FN1. And since it seems like this particular fusion partner is enriched in the urinary tract, that might account for why the bladder myofibroblastic tumors are highly favorable. Just in general, in soft tissue, we think of inflammatory myofibroblastic tumor as having some malignant potential, some capacity for metastasis. But in the bladder, whether it's a pseudosarcomatous myofibroblastic proliferation or an IMT, both of them seem to behave in an extremely favorable way. So some, including the authors of this paper, would say maybe we just lump them all together. And they actually proposed the term pseudosarcomatous myofibroblastic neoplasm of the genitourinary tract to kind of account for this, that they're, perhaps these two could go together as one. Here's another example, some inflammation, some spindle-shaped cells, a little bit more prominent inflammation in this one than compared to our first index patient. Again, a little bit of keratin staining, not as much as our index patient. Again, Desmin positive. Smooth muscle actin, we can see the bundles of muscularis propria, and then the more delicate tram tract staining of the myofibroblastic cells. And then in contrast to our first patient, this one has positive ALK immunohistochemistry. And at the time, we were validating a fusion panel, and so I thought it'd be interesting to test this one to verify the ALK rearrangement, and indeed this one on our fusion testing showed the FN1 ALK fusion. So the way I kind of handle this is, I would interpret a myofibroblastic proliferation in the bladder that's negative for ALK I would use the term pseudosarcomatous myofibroblastic proliferation, although it's debatable, as I mentioned, whether we should just lump those and IMT together into one category. Like I alluded to at the beginning, encountering this patient led me to kind of pursue a small project, and I wondered, there is some similarity of myofibroblastic proliferations of the urinary tract to nodular fasciitis of soft tissue. And then recently it's been found that nodular fasciitis has a USP6 gene rearrangement, so I wondered, could sort of USP6 rearrangement account for these in the bladder that are ALK negative? Perhaps it's basically an equivalent of nodular fasciitis in the bladder. However, in the study, which was published in Histopathology, we found that USP6 was also negative in these lesions, arguing against it representing a version of nodular fasciitis occurring in the bladder. So here's a figure showing a soft tissue nodular fasciitis with gene rearrangement, and then one of these bladder myofibroblastic proliferations, which looks very similar to me, but showing absence of rearrangement. We also tested for some of the less common fusion partners that have been reported in IMT, like ROS1 and ETV6, which were also negative. So some of these myofibroblastic proliferations in our study at least remained unexplained. However, a recent paper from China suggested that maybe there are occasional USP6 rearrangements in bladder myofibroblastic proliferations. In this study, they had 7 lesions, 3 of which are from the urinary tract and were actually positive for USP6 rearrangement. So although in our project we weren't able to find any of those, perhaps it does occur, as there were 3 out of 7 in this study. The remainder in this study were vaginal, so perhaps it's more common in other sites to have actual USP6 rearrangement. And just to show an example of an IMT with a different fusion other than ALK, this is one from the lung. We can see spindle cells and inflammation again, positive staining for SMA, but negative ALK. And this one, using next-generation sequencing, had ETV6 NTRK3 fusion, which is thought to be at least a variant fusion that can occur in some inflammatory myofibroblastic tumors. So coming back to our patient, at the time I was at Henry Ford Health System in Detroit, and this was the chair of urology, Manny Menon, and he had looked up some of my publications and saw that I had published about myofibroblastic tumors of the bladder, and he called me up and said, "Oh, that's very interesting," and I said, "Don't worry, it's benign." And then the patient underwent a partial cystectomy because this was a sizable lesion. This is, again, our original patient we started talking about. And here you can see it looks almost kind of like a leiomyoma, a very white fibrous tumor. And a different urologist did that surgery, and we were having a conference that day, and he said, "We did frozen section on the lymph nodes, and they were positive for spindle cell tumor." And so I started to sweat. And this is what was referred to as the lymph node. And actually, hopefully I can convince you that this is probably not a lymph node at all. Looking at this at higher magnification, it's a spindle cell lesion as well, but perhaps a little bit more eosinophilic than the bladder lesion, some hyalinization and some spindle cells over there. A little bit more kind of compact and cellular without the inflammation. Staining this one, Desmond was positive. Keratin was negative, which contrasts to the bladder lesion. And we have a diffuse estrogen receptor staining in this lesion. That had not yet been done on the bladder tumor, but going back to the bladder tumor, estrogen receptor is negative. And so actually, I was able to get out of my panic and decided that this lesion that was thought to be a lymph node is actually probably a gynecologic type leiomyoma. So in the past, those have been referred to as wandering leiomyoma or parasitic leiomyoma, with the thought that it breaks off from the uterus and grows at a different site. I think the current thinking is probably more so that it actually originates somewhere else in the pelvis of women rather than truly breaking off from the uterus. But due to these immunohistochemical differences, fortunately, I think that was not really a metastasis to a lymph node, but actually a unrelated leiomyoma. And indeed, she had a history of uterine leiomyomas that had had hysterectomy before. So to summarize these myofibroblastic proliferations, I think the relationship of IMT and pseudosarcomatous myofibroblastic proliferation is debatable. But in either case, the behavior seems to be very favorable, so it may not matter which way you diagnose them. The subset that are ALK positive, I do refer to those as IMT. The ones that are ALK negative at current time, I think, remain unexplained, but seem to also have very favorable behavior. For my second case, is a sort of common situation that I encounter in penile specimens. Find a biopsy of a lesion, and then I'm wondering to myself, is this a condyloma? And looking at this particular one, you might say that looks kind of like a seborrheic keratosis. has kind of thickening of the epithelium, and there may be even some structures resembling horn cysts like you would see in a seborrheic keratosis of the skin. That's a bit unusual because we don't really think of the genital tract as a place where you would have seborrheic keratosis. Usually we associate those with skin sites that have a high sun exposure. This one's a little bit more sort of papillary, but again has some resemblance to seborrheic keratosis. So there's not a lot of literature in the male genital tract, but if we look at the gynecologic literature, there are some papers suggesting that if you look at lesions that resemble seborrheic keratosis in vulvar sites, that a lot of them harbor HPV. This study used PCR. Another one here found that HPV was positive in enriched in the genital site seborrheic keratoses, and then not common in seborrheic keratoses that were from other sites. And just one other paper there for your reference showing that a high percentage of the genital site seborrheic keratosis type lesions were positive for HPV. And even this paper in the American Journal of Surgical Pathology showed that there occasionally are sort of large mass-forming lesions of the female genital tract that kind of resemble seborrheic keratosis and which are positive for low-risk HPV. So actually, the way I approach this is if the clinical impression was of a condyloma, I usually would just say that that is compatible with a condyloma, even if the morphology looks more like a seborrheic keratosis. Or if the clinical impression was a bit uncertain, I might give a more descriptive diagnosis, but explain that lesions that resemble seborrheic keratosis on the genital, in the genital sites are often positive for HPV and are thought to be sort of a form of condyloma. Just one other case before I talk about some research that was spun off from this in our group. This was a case where a surgeon did an excisional biopsy of the penile glands, and he thought that there was a hard nodule. And I was sort of confused at first looking at this specimen. We can see around the edge the sort of skin lining, and then there's this kind of cystic cavity containing this papillary verrucous proliferation. And at first I was sort of confused what exactly was going on here. But then upon talking to the surgeon, he indicated that there was a sort of palpable, firm nodule of the glands, and then that the urethral mucosa was diffusely abnormal. So taking that information, I realized perhaps this space here is actually the urethra, in which case the urethra was basically filled with condyloma. So looking at this concept of condyloma that resembles seborrheic keratoses, we recently studied this in our group with one of the trainees in our program. We pulled out penile specimens where the term seborrheic keratosis was mentioned somewhere. Either it was a seborrheic keratosis or the differential seborrheic keratosis was mentioned. And we did chromogenic in situ hybridization for low-risk HPV subtypes and found that almost 70% of them were positive for low-risk HPV. Interestingly, we often think of low-risk HPV, at least in our group, as showing this kind of big, chunky nuclear staining pattern when you have a low-risk positive sample. But only a minority of the specimens in our study had this discrete nuclear staining pattern where the sort of globs of staining are very large. The remainder of them had more of a fine granular pattern like we normally expect with the high-risk HPV probes. And at first glance, you might think that this is negative, but looking carefully, there are some clumps of dark brown staining, some larger granules and some smaller granules overlying the cells, not to be confused with the pigment that you can see at the base of the epithelium on the rightmost edge. This, for example, is an entirely negative specimen where you have the pigment at the basal layer, which is sometimes difficult to distinguish from actual staining using the HPV probes. So when I encounter something that looks like a seborrheic keratosis on the male genital tract, basically my approach is to strongly consider the possibility of condyloma, and if, in fact, the clinical impression is in keeping with that, perhaps just outright diagnose it as a condyloma. And just something to keep in mind, if you do have access to the low-risk HPV cyst probes, it may be subtle to notice a positive reaction. So you may want to look at high magnification for some of these subtle granules. For my third patient, this is a renal tumor. And I encountered this not too long ago in in daily work with a resident working with me, and it was a small lesion, and I looked at this and I said, well, this looks like the entity clear cell papillary renal cell tumor, and I think the resident was feeling the same way. And I said, well, but since we have a trainee, why don't we do the staining to see an example of how the immunohistochemistry works in clear cell papillary renal cell tumor. And here at higher magnification, you can see there's some branching of the glands, some nuclear alignment, and then some papillary structures. So to me, this photo would be great for a textbook for a clear cell papillary renal cell tumor. But then surprisingly, the immunohistochemistry didn't turn out exactly the way you would expect. In the upper right is keratin 7, so there was a lot of keratin 7 positivity. But if we look in the bottom center, there is some positivity for Amicar, which we typically are not supposed to have in clear cell papillary tumor. And in the lower left, there's also CD10 positivity, which we're not usually supposed to have in clear cell papillary tumor. And then finally, in the upper left, GATA3 was negative. I know some authors have had mixed results with GATA3, but at least in our group, it's usually some positivity in a clear cell papillary tumor, especially if you look at high magnification. It may be weak to moderate intensity, but it's usually there, at least in our group. So again, I was sweating, surprised with the results of the immunohistochemistry in this patient. Just a quick summary of what we expect in clear cell papillary. If we think of CD10 and CA9 as our clear cell markers, it's only positive for CA9, but not CD10. If we think of keratin 7 and Amicar as our papillary RCC markers, it's positive for keratin 7, but not Amicar. And then it has this other finding of being positive for distal tubular markers like high molecular weight keratin and GATA3. So clear cell papillary tumor is now considered a tumor rather than carcinoma in the WHO, since it has very, very favorable behavior. You may have seen, though, that there are possible rare reports of metastases. Both of the most convincing reports of possible metastases come from the Mayo Clinic from Shauna Gupta and colleagues. And so it remains uncertain if this is a tumor that's usually benign but can rarely metastasize, or if these rare examples are something else that is sort of mimicking a clear cell papillary tumor. A couple of studies were done, actually one from myself and colleagues before I came to the Cleveland Clinic, and then another one from the Cleveland Clinic team before I came there, both of which we sort of concluded a similar thing, that if you have features kind of resembling clear cell papillary tumor but that are not perfect, we would usually err toward diagnosis of clear cell RCC. And so here's just a little bit of detail which is available in your handout if you want to see some comparison between the two studies. But basically both of us concluded that if the features are not perfect, we would err toward diagnosis of clear cell rather than clear cell papillary tumor. So here's an example of one with branching of the glandular structures and nuclear alignment. Really good example of the nuclear alignment. But then in this one, the keratin 7 was totally negative, or it may be very focal and minimal. CD10 positive. So again, the immunohistochemistry is not right. Carbonic anhydrase 9 doesn't really distinguish between the two, so if you wanted to skip one of the markers, I think you could potentially skip this one. And in our project, we used FISH, which we found that chromosome 3p loss, there was a pretty high rate of chromosome 3p loss in these tumors with imperfect features. And so again, we also would consider that to favor diagnosing as clear cell if the features are imperfect. Also, a strange thing is that in the setting of von Hippel-Lindau disease, sometimes the tumors kind of resemble clear cell papillary tumor, which is paradoxical because patients with VHL disease have a germline mutation of the VHL gene, but all of the sporadic clear cell papillary tumors that have been studied with genetics are lacking VHL alteration. So it's unclear why they would closely resemble this entity, despite that the sporadic version of the clear cell papillary tumor never has VHL mutations. But nonetheless, if I encounter a tumor that looks a lot like a clear cell papillary tumor, again, staining is imperfect and the patient is very young, often I make a note that the possibility of VHL disease could be considered. And in fact, I would do that anytime that a patient is exceptionally young. The National Cancer Institute suggests under age 46 is sort of suspiciously young for developing a renal cancer, and so you may want to consider genetic testing. So, what did I learn from this case? It's debatable whether you need to always do immunohistochemistry to make a diagnosis of clear cell papillary tumor, but this one looked so closely like a clear cell papillary tumor, I think it shook my confidence in making the diagnosis completely on morphology alone. And so I probably would continue to do immunohistochemistry in most of these. And my panel is probably a little bit bigger than that of other colleagues in my group, but I usually do all of those markers that were shown in the table versus others who might do only keratin 7. And for my last of the cases that I was going to mention here today, this is a testicular mass. And so here you can see a big area of hemorrhage in the testis, some normal seminiferous tubules at the left side. As we zoom in, we don't really see any tumor cells per se. There's this area of hemorrhage, and then we see this blood vessel, which is sort of suspicious. It has funny thickening of the intima and some inflammatory cells within the intima. Here are some other vessels from around nearby in the same specimen. Again, the intima is much too thick, and there are these sprinkling of lymphocytes in the intima. If we use a trichrome stain, we should basically have the media and then a very minimal, negligible amount of intima on top of it, but here you can see the intima in blue is very thick. There's a substantial amount on top of that medial layer. So one of my colleagues who's now recently joined us at Cleveland Clinic, but we trained together at Indiana University, Sunny Kao, she looked at a series of patients that had this constellation of findings where the testis presented with what seemed to be a mass, and then it turned out to be just an area of hemorrhage and infarct. And then there was no tumor appreciable, but if you look around, you would see damaged blood vessels in the background. And their hypothesis was that this was kind of the result of multiple vascular injuries over time. They thought chronic intermittent torsion was a likely explanation for this. So the vessels are becoming repeatedly damaged, and eventually it reaches a breaking point where there's been so much vascular damage that you develop an infarct or an area of hemorrhage. And so you might say, well, these findings look a lot like vasculitis, but on the follow-up, they found no contralateral involvement or systemic disease, suggesting that there was no evidence of systemic vasculitis. Here's just a higher magnification again with some of those inflammatory cells thickening the intima, and again, the trichrome with this marked thickening of the intima and sprinkling of inflammatory cells in there. In the paper, actually, some of the vessels had almost a fibrinoid necrosis like you would think of in, say, a polyarteritis nodosa type pattern. And for comparison, they looked at cases of classic torsion where the clinical impression was torsion and the testis was entirely infarcted. And they also found fibrinoid necrosis like this in cases of classic torsion, suggesting that it is possible to develop this appearance of fibrinoid necrosis that's not necessarily true systemic vasculitis. So there have been studies describing vasculitis in the testis, but many or most of those patients didn't turn out to have any systemic disease. So I would wonder whether a lot of the publications of testicular vasculitis actually represent this phenomenon. Here was a study from the Hopkins group, and they had a similar conclusion that most patients with testicular vasculitis didn't have systemic findings, but it was more likely that there would be systemic findings if the vasculitis was granulomatous. So that may be a clue to be more suspicious of true vasculitis if you have granulomatous inflammation. And then again, a study that features some of our cardiovascular pathologists from the Cleveland Clinic, they looked at testicular vasculitis as well and found similarly that most of these patients didn't have systemic disease and that the pattern was most like polyarteritis nodosa. So my approach, when I encounter a lesion like this, I describe that there's an area of hemorrhage, necrosis, and that the blood vessels are damaged. And I cite the study from Dr. Cow and colleagues suggesting that this perhaps results from chronic intermittent torsion or some other form of chronic vascular injury, which eventually reaches a breaking point and causes a hemorrhage or hemorrhagic mass lesion. If you were to do serum vasculitis markers right after the patient has had surgery, my cardiovascular colleagues say that the markers would be likely elevated. And so they suggest that if you wait until the patient has recovered from the acute surgery, and then do serologic markers, then it would be more informative. And so I give a note explaining that if there's any reason to suggest systemic vasculitis, they can pursue that. However, in many of these patients, there turns out to be no evidence of systemic disease. So what else might be in the differential diagnosis of a hemorrhage or an infarct in the testis? Occasionally, testicular tumors can spontaneously regress, and even though the primary tumor has regressed, there may be metastases elsewhere. And so a very nice study from Drs. Balzer and Albright was published a number of years ago now in American Journal of Surgical Pathology, proposing criteria for how to recognize a regressed germ cell tumor. This is a patient who had been diagnosed in a biopsy with metastatic germ cell tumor, and then upon orchiectomy, we just have seminiferous tubules here. You might be able to make out some germ cell neoplasia in the lower right, and then a big chunky calcification in the upper left. And I'll sort of show what we think is the significance of that calcification. So here's a chunky calcification in the scar area. And in the study by Balzer and Albright, they proposed that probably these chunky calcifications represent embryonal carcinoma that previously was growing within pre-existing tubules, undergoing necrosis, and then undergoing calcification. And then when the tumor regresses, all that you have left are these nodules of calcification. That's not to be confused with microlithiasis, which is more of a small round calcification in the seminiferous tubule, which does indicate that the testis environment is abnormal but is not specific for tumor. It's actually more common that you can have microlithiasis in the testis without any tumor. So big chunky calcification would be suspicious for regressed embryonal carcinoma, but microlithiasis not necessarily specific for tumor in and of itself. And so if you have either that or you have germ cell neoplasia in situ in the background testis, they propose that you could confidently diagnose this as a germ cell tumor that regressed. And here's a higher magnification showing larger cells with prominent nucleoli along the basement membrane of the seminiferous tubule, like seminoma cells basically, but arranged in that linear layer at the basement membrane, representing germ cell neoplasia in situ. You can use OCT3/4 staining if you wanted to confirm that diagnosis. So how would I report these out? I would say, scar, and if you have one of these findings, I would say scar with whichever finding is present, consistent with regression of germ cell tumor. Sometimes clinicians use the term burnt out germ cell tumor, which is a synonym. But if you don't have either of those two findings, so you have a scar but no GCNIS and no chunky calcifications, I would still make a comment that the possibility of regressed germ cell tumor cannot be excluded. And actually, talking of cases that I learned from in GU pathology, there was one a year or two ago where my colleague brought it to me. We saw there was a scar, but we really didn't see any of the other features to suggest that it was a regressed germ cell tumor. And we were debating, should we put the comment saying that it may be a regressed tumor or not? We ended up thinking there wasn't anything suspicious that suggesting it was a regressed tumor. But then sure enough, later the patient was found to have metastatic germ cell tumor. And so the sort of thing that I learned about from a case like this is I pretty much would always make a comment that a scar in the testis could represent a regressed tumor. Since it's something you wouldn't want to miss. So then they could follow that up with serum tumor marker testing and checking the retroperitoneum for sites of metastases before dismissing it. What else is in the differential diagnosis? Choriocarcinoma can also have areas of hemorrhage and necrosis, but you would also need the tumor cells, the multinucleated syncytial trophoblastic cells and the mononuclear trophoblast cells. And here's an example. We have hemorrhage, giant cells, and mononuclear cells. Sometimes the giant cells have kind of a lacuna with blood in it. Like here we can see these big cells wrapped around an area of blood. And if you want to use some immunohistochemistry, OCT3/4 is negative in choriocarcinoma. That would help distinguish it from either seminoma or embryonal carcinoma. And then GATA3 is often positive in trophoblastic tumors. So in summary, for this concept of testicular vasculopathy and hemorrhage, sometimes you get a mass composed of hemorrhage and infarct in the testis, which clinically presents as suspicious for a tumor. They remove it because they're thinking it's a tumor. So I would usually look at the adjacent blood vessels, and if you see that damage to the adjacent blood vessels, I make this comment like we talked about earlier, explaining that Although there are some features resembling systemic vasculitis, often these patients have no clinical symptoms afterward, and don't develop any signs of further vasculitis. So those are the cases for me. I think probably we should wait until the end for questions, just to make sure we have enough time for questions. This is a character, he's representing GU pathology here, but if you've ever heard of this character, it's named Gudetama. It's a Japanese character that is a lazy egg, but I'm using it to be a cheerleader for GU pathology here. So thanks again, and I'll pass it over to Dr. Giannico for the second part, and then I think we can take some questions after that.
Thank you, Sean. Perfect, thank you so much. Good morning, everyone. Can you hear me well? Okay, perfect. I would get started so that we have time at the end to get your questions. These are a few of the cases that I learned. These are actually recent cases that I had this year, and so I wanted to share these with you. I will talk about some cases in bladder pathology, penile pathology. I also have a case in prostate pathology that I have not listed here, but it's actually going to be in here. So this is case one. This is a 31-year-old man with history of gross hematuria. So please note the age, young person. The patient presented with urinalysis that had large amount of hematuria as well, but he had no UTI symptoms. And in clinic, cystoscopy showed a 3 to 4 centimeter papillary tumor at the trigone. And these are some representative sections. I had multiple pieces. It was a great specimen. Many of these pieces show this papillary proliferation that we could not really diagnose other than papillary urothelial carcinoma. It seemed that there was limited degree of cytologic atypia, but there was no significant pleomorphism or significant hyperchromasia, no mitosis that I could see. So it looked to me like a classic run-of-the-mill low-grade papillary urothelial carcinoma. However, many of the pieces, and just really many, not just these two that I will present, had this tight, compact, nested proliferation that was undermining the surface tumor, and it was in the lamina propria. And you can see I've chosen a couple of these areas that should show you that it was in multiple pieces. It was very similar everywhere. It was present, and when we looked at these a little at higher power, you could notice that there was a higher degree of cytologic atypia in these nests than in the surface papillary tumor. And additional findings were some minor, not minor, but rather small superficial foci of lamina propria invasion. You can see some single cells or nests with retraction artifact here. You can see several single cells. There are actually many more than my arrow can show. So nest with retraction artifact here, you can even see some single cells. There is another one next to the vessel, and potentially there is a cluster there that could be potentially considered lymphovascular invasion. So I would like to invite you to give me a differential diagnosis, because here I had a lot of differential diagnosis. So I'm going to start this poll. If you would like to scan the QR code. Okay, and I am going, if you all are right already, I'm going to start. Okay, so it looks like 60% are considering roughly a little bit more high-grade papillary urothelial carcinoma invasive with an unusual non-invasive nested urothelial component. Some are considering cystatic cystic and glandularis. Some are considering, nephrogenic adenoma there. And some are considering pseudocarcinomatous urothelial hyperplasia. Yes, those are all potential possibilities. I consider all of these. I was really puzzled with that case. And the reason why I was puzzled was because, as I mentioned, the patient is 31, and I did consider a nested urothelial carcinoma. And nested urothelial carcinoma will immediately trigger the word radical cystectomy in urologists. And I was not sure that was a nested urothelial carcinoma, and I did not want to have a 31-year-old undergo a radical cystectomy. So this is the reason why I wanted to present this case today. First of all, because I thought it was diagnostically challenging, and second of all, because it raises the issue of diagnosing urothelial carcinoma with divergent differentiation. And so there are a couple of papers that showed how diagnosing divergent differentiation made a difference. In particular, when these cases were reviewed as a second opinion, one of these papers showed that there was a potential treatment alteration in about 15% of cases, with 12% imparting major changes, which were affecting changes in recommendation for radical cystectomy, changes in primary tumor type, and changes in chemotherapy regimen. So these are all significant management decisions that were made secondary to a second review. And it appeared that the diagnosis of subtype histology was one of the major areas of inconsistency, with variant histology not recognized or documented by the contributing pathologist in 44% of cases, and up to 27% of cases of urothelial carcinoma diagnosis being changed upon re-review by a GU pathologist. And in particular, the subtypes histology that were less likely to be recognized were lymphoepithelial-like and plasmacytoid, nested, micropapillary, and small cell, whereas squamous and sarcomatoid and glandular differentiation had a good reporting correlation. And I also wanted to show you why this is important. If you think of the NCCN guideline and the risk stratification of non-muscle invasive bladder cancer, you will see that there are three categories of risk based on AUA American Urologic Association risk stratification guidelines, which stratifies the tumors in low, intermediate, and high risk. And among tumor of high risk, you can see that very high risk features are actually conferred by the presence of variant histologies. And if we look at the management in non-muscle invasive bladder cancer by risk group, in patients that have high risk, you will see that the recommendation in patients that have very high risk features, which are defined as lymphovascular invasion, prostatic urethral involvement, subtype histology. So the recommendation in patients with very high risk features, as opposed to patients with no very high risk features, are cystectomy as preferred treatment in patients with very high risk feature versus BCG in patients without no very high risk feature, even in the setting of a high risk category. So our diagnosis of divergent differentiation is extremely important. Now, going back to our case, I definitely considered unnested urothelial carcinoma, as I mentioned, but I was worried that this was a 31-year-old, and he could have been overtreated if I had made the diagnosis. So nested urothelial carcinoma by WHO has been classified in nested and large nested. I will not discuss large nested today. That's a completely different entity. I will discuss nested urothelial carcinoma, and this consists, as you know, of proliferation of small round ovoid nests. They typically lack cytologic atypia. In fact, they are very difficult sometimes to differentiate, especially in small specimens from von Brunn's nests. So they lack cytologic atypia, but they do have architectural atypia. So I think of nested urothelial carcinoma as being similar cytologically to von Brunn's nest, but being different architecturally, because as opposed to von Brunn's nest, nested urothelial carcinoma nests are irregular, tend to be confluent, and instead of running parallel to the surface as von Brunn's nests would do, they tend to grow deeply, vertically, and haphazardly. So this is what really helps me to recognize nested urothelial carcinoma as opposed to von Brunn's nest. And there is also a complicated factor that oftentimes nested urothelial carcinoma may not even have an in situ component. I also wanted to mention that also it may occur as impure form, or it can be associated with other form or conventional urothelial carcinoma. So nested urothelial carcinoma apparently has high rates of muscle invasion, extravesical disease, propensity for metastases. On a comparison study of 52 nested variant cases compared to conventional urothelial carcinoma controls, the nested variant was associated with a high rate of local advanced disease and radical cystectomy. However, when cases were compared and were matched stage by stage, there was no significant difference in recurrence-free or cancer-specific survival at almost 11 years. Molecularly, these are nested urothelial carcinoma is a luminal subtype, and the most frequent molecular alteration is the presence of third promoter mutation. And I say this because I feel that it's a very useful marker in the setting in which you may have limited specimens, such as a biopsy or a transurethral resection, where you don't have sampling of muscularis propria and where you have this nested proliferation in the lamina propria. So in this setting, third promoter mutation is very helpful because it would indicate the presence of a nested variant as opposed to benign proliferative cystic glandularis or von Brunn's nests. Other alterations are P53, JAK3, beta-catenin, PIK3CA that are useful if we think of the potential for targeted treatment with PI3K, mTOR, and AKT inhibitors. And different from other forms of urothelial carcinoma, there is no significant amount of FGF3 alteration in this cancer. And other forms of molecular alterations that are present in other forms of urothelial carcinoma are not known to be present in nested urothelial carcinoma, in that we don't have data. For example, DNA damage repair genes would be able to stratify patients that could benefit from cisplatin chemotherapy, or PD-L1, tumor mutation burden, or microsatellite instability that would be able to predict response to immune checkpoint inhibitors, or MTAP, a marker that people have been writing about a lot in the last couple of years. We don't have any data in this subtype of urothelial carcinoma. There has been a study that has actually described the features of nested urothelial carcinoma in the upper tract, which is extremely important because especially in the upper tract, we may have urothelial von Brunn's nests, and they can be even florid in this location. So at this location, nested urothelial carcinoma was more frequently associated with an overlying low-grade component and had most commonly large nested patterns, so not the small nest that I've been describing, the nested variant. Behaved less aggressively, interestingly, and had more pathogenic mutation in the FGFR3, PIK3CA, and we have seen the FGFR3 is really not common in the regular variant of nested carcinoma, with a low mutational burden and microsatellite stable. And these are some of the images of nested urothelial carcinoma. As you can see, these are nests that look extremely bland, but tend to be fused and tends to grow deeper. And once again, to show you how bland these may look. This is another example. These are easy in cystectomy specimens because you have the muscularis propria. You can see that these are growing deeply in a vertical way. More of this tumor in the muscularis propria. And let's not forget to consider other benign mimickers. Nested proliferation in the deep portion of the bladder, especially without a surface urothelial component in situ, could be a paraganglioma, which, as you know, they sit in the bladder, in the outer wall of the bladder. So they will be present in the deep levels. And these can also be nested and can have bland cytologic features. But just remember to look at the amphophilia of the cytoplasm as a clue. These are examples of florid von Brunn's nest in the pelvis, renal pelvis, or calyces. As I said, at this location, they can be very florid, typically more than in the bladder. And so, especially at this location, they can be a pitfall. And this is an example of pseudocarcinomatous urothelial hyperplasia, which is a fancy word to basically mention radiation cystitis. And this can have bland to slightly atypical squamoid nest in the lamina propria. It's just part of this lesion, but do not forget to look at the background. There is an inflammatory background, and then the patient typically will have a history of radiation. Especially these patients will have been treated for prostate cancer and radiation in the past, or may have history of catheterization or stones. So something that reminds you of a reactive background. And here there are tons of neutrophils. There's edema. There can be vascular ectasia, fibrin thrombi in the vessels, and a lot of red blood cell extravasation and hemorrhage in the lamina propria, and also without any in situ component. So this is a mimicker, benign mimicker for those nested proliferation. And then typically the literature puts inverted papilloma as a mimicker. I do not find really inverted papilloma to be a mimicker for nested urothelial carcinoma myself, in that, yes, you can have nest, but more likely you will have anastomosis in trabecular or islands of tumor with this palisading at the periphery. So I don't find this to be particularly a pitfall, but this is in the books. And typically, remember, inverted papilloma needs to have a smooth surface, should not have a surface exophytic component. If there is both an exophytic or an endophytic component, think of either Panlamp or an inverted low-grade urothelial carcinoma at this point, or urothelial carcinoma in general, because inverted papilloma per se should have a smooth surface. So my diagnosis was high-grade invasive papillary urothelial carcinoma, rising in the background of low-grade. And the part in red, I didn't put in the diagnostic line because our urologist would have been perturbed, but I did put a comment that there was an exophytic papillary component that is low-grade. In areas there is a nested urothelial proliferation directly below or adjacent to the papillary component. It is tightly packed, nested with a greater degree of cytologic atypia, and the compact arrangement of these nests, their uniformity and lack of vertical growth suggest that this is not a nested variant of urothelial carcinoma. And once again, I thought this was extremely important in this patient that was so young. Okay, I am moving on to the second case, and this is a 71-year-old with a history of phimosis, balanitis, and a small ulceration on the right inferior aspect of the foreskin, presenting for circumcision. So this is the specimen that I received, and for those like me that are looking at these shapes, this look like a dragon head with a little bit of a lichen sclerosis in areas. And you can see there is homogenization of the very superficial collagen plate there. And then in areas, however, there was some atypia of the basal layer, and I'm going to get closer to that. As you can see here, there is also mitotic activity. So at this point, I was also kind of worried, was this real atypia? Or I see there was an edematous area nearby, but there was no clear-cut ulceration. So I did a Ki-67, and I said, okay, let me see, is this any different? And indeed, it did look slightly different. So I did consider that, of course, next to lichen sclerosis, there could be differentiated PIN, and I ran P53, and as you can see, most of the lesion that I was worried about appeared to be 53 null mutant, and there was then, I'm going to show you the details, there are only a few suprabasal positive cells there, but the basal cells are all completely negative, and however, the area just next to the lesion showed this wild type with discontinuous P53 expression at the basal layer. However, surprisingly enough, because I do these lesions, I do P53Ki and P16 in all these preneoplastic lesions in the penis, this will turn out to be actually P16 positive. So, differentiated PIN was my differential diagnosis, but that really should not be P16 positive. And there is there are some negative area, but there are definitely some positive areas that are block positive, more than 80% of the cells in that area. Okay, so I want you to give me your differential diagnosis now. Okay, I'm going to start the poll. Okay, so seems like most of the audience is preferring differentiated PIN with lichen sclerosis, but some are also considering flat condylomas. Definitely something that I definitely considered and both were in my differential diagnosis, so we worked this up a little bit more. Okay, so a few words on PIN in the penis. We really don't use the terminology squamous cell carcinoma in situ anymore, but we use this WHO-accepted terminology, which is penile intraepithelial neoplasia. And similar to its invasive counterpart, it is classified into HPV-associated and HPV-independent, with the associated being classified into basaloid, warty, and mixed, mostly, and with other rare subtypes, and then HPV-independent really being differentiated PIN, but with other entity or subvariant reported in the literature, such as if we consider differentiated PIN as being the central, let's say lesion in the spectrum, we have a low-grade lesion that would be hyperplasia like differentiated PIN, and then we have a higher grade lesion on the other side of the spectrum that would be pleomorphic differentiated PIN. These patients that present with HPV-associated PIN are, first of all, it's the most common of all PIN lesions. Patients tend to be relatively younger. Typically, lesions occur in the plab, in the glands, and they are erythematous, can be unifocal or multifocal. Remember the bowenoid papulosis, that is a lesion that it's multifocal and occurs in younger men, and this is associated with HPV 16 and 18. However, it can spontaneously regress in some cases. Patients typically have a history of condylomata, and typically this is not associated with lichen sclerosis. And these are some examples. This is warty PIN. You can see that there is an acanthotic lesion with hyperkeratosis and parakeratosis and coilocytosis. That's typical of warty PIN. And it's a little bit more atypical than a condyloma, otherwise P16 positive. This is basaloid PIN, which looks like a papillomatous lesion with lots of these very undifferentiated basaloid-looking cells with high NC ratio, marked atypia. You can find a lot of mitosis and apoptosis. These are also typically P16 positive. And then you can have this mixed lesion where you can see this is a warty basaloid lesion where you have once again P16 positive, and you have a warty component at the surface with this colocytic atypia and a basaloid component at the base. And this is another variant of mixed where the two lesions are not overlapping, but they are actually separate spatially separate in the specimen, where you can see that there is a papillary basaloid component here that is HPV positive, and then there is a warty basaloid component next door that is also HPV positive. As opposed to HPV-associated, HPV-independent PIN occurs in older patients and can also be unifocal and multifocal. It more likely occurs on the foreskin as opposed to the glands, and it looks more like white plaques as opposed to erythematous plaques, and it's more typically associated with lichen sclerosus. And this is an example where you can see slightly thickened skin or squamous mucosa with acantholysis on the surface, but there's still maturation if you think about it on the surface, whereas the base looks pretty atypical with probably several mitoses as well. There was no lichen, there is probably only minimal lichen sclerosis, but in this particular specimen. And then if you did P16, these would typically be negative. And so this is why our case was challenging, because it had that P16 positivity. Okay, so differentiated PIN, as you know, it's associated with lichen sclerosus, and this can be associated in different forms, in different spatial configurations. And typically, from the older literature, it emerged that these are P16 negative, as you all know, Ki67 positive, basally and suprabasally, and P53 variable. So in the penis, P53 a little bit more variable than what happens in the gynecologic tract. So it can be null, patchy, or diffuse suprabasal. So let's look into that. So there was a paper in 2017 that looked at the association of P53 gene mutations in patients with HPV-independent penile squamous cell carcinoma, and they found that in their cohort, 76% had somatic P53 mutations, and when they did immunohistochemistry, they had that 60% of these cases, 19 out of 33, had nuclear P53 staining, and 14 cases were negative, what we would consider null mutant. Of the cases that were positive, 12 out of 19 had greater than 90 P53 expression, what we would consider overexpressed mutant, and 7 of 19 had the papers talks about heterogeneous expression, so I would assume that they consider this wild type. But all these, 18 or 19, so most of them did have mutations. And for the cases that were negative null mutant, half of them had P53 mutations. So if you look at the cases that had mutation and did express mutant, whether overexpressed or negative P53, the authors suggest that there was only 75% correlation of the stain with the mutation. And so they suggested that if we wanted to analyze for mutations, that we would have to do it by sequencing and not by immunohistochemistry, because there was only 75% of these were detected. In more recent years, and this is a paper from last year, some authors have studied by next generation sequencing the molecular phenotype of tumors, squamous cell carcinomas that are HPV associated, and tumors that were HPV independent. For tumors that were HPV associated, you can see that there is a very distinct genomic molecular abnormality that underlies these lesions, with most of the tumor being mutated for PIK3CA and some of them for FGF3 and PTEN. Whereas if you look at the HPV-independent tumor, the overwhelming majority has P53 mutation and CDKN2A mutation, with some HRAS mutations. So this is interesting. There's a distinct split in the molecular. And this makes sense if you think that tumors that are HPV independent definitely do worse than tumors that are HPV associated. So a more recent paper from a group in Austria has suggested that there could be at least 2 different genetic pathways in HPV independent PIN. And I will explain this in the next slides. One pathway associated with mutation in tumor suppressor genes, and these have a background of chronic inflammatory skin disease in the precursor lesion, and this is the classic DPIN. And then there is another pathway with lesions that look verrucous and verruciform, so they don't look clearly as DPIN. Probably these are the lesions that in the pre-existing literature were considered the hyperplasia-like, so the lower spectrum of DPIN, that have different mutations. At this time, they are not tumor suppressor genes, but rather they are activated oncogenic mutations in proto-oncogenes, and they don't have inflammation. So if we look at that, and I will go over this with you because I think it's extremely helpful to understand these precursors. So there is a pathway that goes through P53 and CDKN2, and there is a pathway that goes through, and this is all in HPV independent neoplasia, and there's a pathway that goes through PIK3CA and HRAS. And if we look at these lesions, with regards to the association with chronic dermatosis, the former has association with dense lichenoid infiltrate, and the latter does not. There is a third category that is so-called undifferentiated because there are really no specific molecular alteration. We'll keep that in mind for now. With regards to P53 immunohistochemistry or molecular alteration, in the DPIN category, we have 2 classes. One that has P53 nuclear overexpression, and one that has there is P53 null. The former associated with P53 missense mutations, and the latter associated with P53 truncating mutations. Whereas the verrucous precancer, the one that look more low grade, do not have any P53 alteration. This is very similar to what is being also discussed in the vulva as well, if you do gynecologic pathology as well. And these undifferentiated cancer, they are undifferentiated in that they don't have any specific feature. With regard to P16 and CDKN2 alteration, that CDKN2A is actually the gene for P16. In the DPIN class, there are cases that can be P16 negative with no CDKN2 mutation or truncating mutation, and others that have CDKN2A overexpression. And this is our index case, right? Because this looked at DPIN with positive cytoplasmic and nuclear P16. And these have missense mutation for this gene. In the verrucous precancers, there are none of these mutations, and there are mixed mutation in the undifferentiated forms. So if we want to look at these, the first group is the group that has classic DPIN morphology. And once again, you can have alteration of P53 that is null or overexpressed, or it can be, you can have P16 positive or P16 negative in these cases. And then we have the verrucous precancers, those that we would have called squamous hyperplasia or hyperplasia-like DPIN, so a step in a lower grade sense, if you wish. And these can be keratinizing or non-keratinizing. And these are the verruciform precancers. And then there are these undifferentiated precursors. And this image actually contains both in the author, in the first two H&Es, such as this and this, they were referring to the non-keratinizing verruciform precancers, whereas the last two pictures, this and this, they were referring to the really undifferentiated basaloid precancers that I've described as a mixed category. So I think this is a very interesting work that these authors have done in HPV-independent penile intraepithelial neoplasia that definitely would explain our index case. A few more things. There have been the case reports of HPV-negative penile intraepithelial neoplasia with basaloid features, which is unusual because, as you know, basaloid PIN is typically associated with HPV infection. And they had 5 cases. They were all P16 negative, and they were all HPV low risk and high risk negative. And then, as we would expect for HPV negative, most of these cases actually had alteration of P53. So keep that in mind. And keep also in mind that cases of HPV-associated squamous cell carcinoma with P16 negative has also been described. These were P16 negative, but HPV positive by PCR. And these can be, the P16 negativity can be explained by nonsense CDKN2 mutation in these cases. So if we want to summarize, we may have at least 2 genetic biological pathways where you have one that has TP53 mutation that is associated with what we used to call in the literature classic PIN, and then one that is P53 wild type and that it has these verruciform precursors, and what in the literature we would have, or what I would have called until this paper, squamous hyperplasia or hyperplasia-like DPIN. So these more thickened lesions that are next to more aggressive lesions, but you don't know what to do with them in the end. And then there is this undifferentiated basaloid PIN. Could this be what we used to call pleomorphic PIN? I'm not entirely sure because pleomorphic PIN, it really isn't basaloid. So there is more to learn from these lesions. In our case, I did, given that P16 positivity, I did high-risk HPV cocktail, which was not detected. So as most of you diagnosed, yes, that's what I diagnosed as well. I diagnosed this as differentiated PIN with lichen sclerosus. And how do we work these up? I do, as I mentioned, especially in the precursors, I do P16, Ki67, and P53, and most of these are straightforward. So if I have a continuous linear nuclear P53 overexpression, continuous at the base, at least 80% of the cells in a stretch, I call this diagnostic for HPV independent. If I have a null pattern of P53, also this is classic for HPV independent DPIN. And if I have a discontinuous wild type pattern, then I think of that as the result of an ischemic and inflammatory stress in basal keratinocyte in this hypertrophic dermatosis that should be not overinterpreted as PIN. And then what do we do with these more equivocal scenarios where you have these verrucous HPV-independent penile precursors or just benign reactive squamous proliferation or these hypertonic chronic inflammatory dermatosis? So these are hard, and sometimes I don't even know what to do. So I send pictures to my friends that are more expert than I am in penile neoplasia. But definitely, abnormal maturation and keratinization may be helpful in that it may assist in correctly diagnosis the verrucous precancers because prominent parakeratosis is not a feature of a lichenoid dermatosis or benign squamous hyperplasia. So this prominent parakeratosis may orient you to these newly described verrucous precursors. They were saying that they are precursors now. And then If I have an HPV-independent basaloid full-thickness precursor lesion, which is unusual, then I'll do P16. And if there is lack of P16 but concurrent P53 mutation, then I think of these as these precursors. And so as a take-home message, overall, not all histologically typical DPIN express P53, and some rare HPV-negative precursor lesions may show P16 positivity, like our index case, due to CDK and 2A missense mutation. There are some rare HPV-negative precursors lesions that may have basaloid morphology, and then seemingly benign verrucous and verruciform proliferative lesions are true precursor lesions. Okay. And then I think I want to do this in 10 minutes, hopefully, so that we have 10 minutes for Q&A. This is a prostate case that I had actually not less than a month ago, and I thought it was very interesting because I learned a lot from this case. So this is a 71-year-old man with elevated PSA and symptoms of chronic obstructive lower urinary tract infection, lower urinary tract symptoms. On MRI, he had a mixed cystic and solid mass that was contacting, per radiology report, the posterior prostate and anterior rectum, measuring 8 centimeter, with superior rectal adenopathy suspicious for malignancy, possibly cystadenocarcinoma. On colonoscopy, there was no intraluminal involvement of the mass. The patient declined a transrectal biopsy, and a robotic prostatectomy was done with excision of the seminal vesicle, mass, and a pelvic lymph node dissection. On operative note, the surgeon found this large cystic seminal vesicle mass bilaterally adherent to the anterior rectum, and he didn't see these enlarged lymph nodes that were described on MRI. So I actually have the mass here, and forgive me, I have to remove the patient's information from here, the patient accession number. So you can see that this is the prostate, this is the apex, this is the base, this is what we have of the vas deferens here, and this is the mass that was all in the location of the seminal vesicles. Okay, so here I actually have this already pulled, so we don't have to wait for the slide to... Okay, we may have to wait for the slide to refresh. Okay, so this is one of the representative slides. I chose this because I wanted to show you that although this had the seminal vesicle attached to this lesion was next to the seminal vesicle, in reality, the seminal vesicle had a nice fat plane, and so it looks like the mass was not associated with the seminal vesicle, at least grossly. And as you can see here, the mass had this cystic component. A lot of it looked very similar. Within these cysts, there were these kind of tufted epithelial proliferations. But let's get closer. And we just have to give it a minute because there's a lag in the focusing. Okay, so if you look at this, when it will become better in focus, it looked to me like the glands were all benign, were just all benign. It looked to me, I could even see basal cells, low power. If you looked at I think it's not yet in focus. Oh, there you go. If you look at the stroma, it looked to me like prostatic stroma after all, not particularly hypercellular, because one of the first things that triggered was, and I will let you do the differential, but I thought of a stromal tumor. And I just want to show you that, I'm not going to spend too much time on this. I just want to show you that the whole lesion looked like this, with something that looked to me like prostatic stroma and benign glands. So if we go back to the presentation. Okay, so then I did NKX3, I did stains. So as you can see, the prostatic glands were NKX 3.1 positive. I did AR, androgen receptor, both prostatic glands and stroma were positive. CK7 was negative in everything. There was some minor positivity in some of the cystically dilated glands. Progesterone receptor stained the prostatic stroma as expected. CD34, although sometimes, in most cases, CD34 should highlight the prostatic stroma, in this case was only highlighting the vessels. And then I did Ki-67 that was not overwhelming. And then I did STAT6 because I always think of SFT in these stromal lesions of the prostate, and it was negative. So I want you to, if you have, apologize for the case 4, I changed the position on my cases, so this actually is case 3, not case 4, but I couldn't change this. So I'm going to start the poll when you're ready. Okay, so let's see what you think. So many are considering a giant multilocular cystadenoma of the prostate. Another component is considering a STUMP, stromal tumor of uncertain malignant potential. And a minor component is considering cystic degeneration of BPH. That's exactly what I thought. Definitely, I didn't think this was a carcinoma. Okay, I think we are mostly settling into giant multilocular cystadenoma of the prostate. Okay, some people are thinking seminal vesicle mixed epithelial stromal tumor. Absolutely. That's absolutely a consideration. Okay, I'm going to move on. So, as you said, I did consider, actually, that was my first consideration, given how the MRI described the lesion, how the surgeon described the lesion, how the gross specimen looked like. There was enwrapping the seminal vesicle. So as you know, in the seminal vesicle, really, we don't have a lot of pathology, but we can have cystadenomas, we can have adenocarcinomas, we can have very rare cases of squamous cell carcinoma and MESTs, mixed epithelial stromal tumors. So some people actually consider cystadenoma and MEST like the same entity on a range, on a spectrum where low-grade, almost like fibroadenoma of the breast and phylloides tumor, where the fibroadenoma is the lower stromal component, like the paucicellular in the stroma, and phylloides becomes hypercellular in the stroma with other additional features. So these authors consider cystadenoma as the low-grade MEST, whereas in the WHO, I believe that they keep cystadenoma separate from the MEST, and MEST are the lesions that have hypercellular stroma. But anyway, however you consider them, they generally are benign. I definitely did not think it was an adenocarcinoma, and as you see, I did immunohistochemistry, and typically the seminal vesicle epithelium is positive for CK7 and PAX8. I didn't do PAX8, but CK7 was negative. And I did NKX3. I also did PSA and PSAP, and I also did AR. I overstained this, and they were all positive, showing that this was not seminal vesicle epithelium, but rather prostatic epithelium. So I kind of eliminated the hypothesis that this could have been a seminal vesicle lesion. And then here we go, we have our STUMP. So I thought this could be STUMP or BPH. Yes, both of them. I wasn't really sure. So how do we distinguish STUMP and BPH? I definitely didn't think it was a stromal sarcoma. There was not enough hypercellular erythropoiesia or necrosis for that matter. So typically BPH is nodular, whereas STUMP is not, and definitely not high-grade stromal sarcoma. Typically, BPH has thickened stromal vessel. STUMP, less likely, and definitely stromal sarcoma does not have. BPH does not have stromal atypia. STUMP may have stromal atypia in some subtypes. Stromal sarcoma definitely has stromal atypia. Mitosis should not, and necrosis should not be present in STUMP. And if you do see them, just remove your STUMP as a diagnostic hypothesis. In BPH, similar to into STUMP, you should not have any of them. You can have mitosis and you can have necrosis in stromal sarcoma. So this is an example of BPH. You can see, although there is not a capsule, but BPH tends to have this very well demarcated border. BPH tends to have these thick vessels that are, if you focus on them, you'll see so many, and they almost looks like they're coming out of the stroma open towards you. There are just many, many, many. They're really easy to find if you concentrate. Whereas this is less likely to be found in STUMP. So this is very, very helpful as a finding, because I've seen STUMPs that were very well demarcated, as well as STUMP that were infiltrated. So in the STUMP, we can have 5 histologic patterns. And I can actually go through them. Hypercellular with degenerative atypical cell, the most common hypercellular with fusiform cells, phalloides, myxoid, and hypercellular with round nuclei. I don't have an example of this. There is a paper that described 5 cases, so I'm not really sure how common is to find this entity, but I can definitely show you this is the most common one that I found myself with these degenerative looking atypical spindle cells in the stroma. This is the myxoid ones. Typically the myxoid lacks the association with the benign glands because don't forget stump are like fibroadenoma in the breast, so they are fibroepithelial proliferation. So along with the stroma, you have an epithelial proliferation. Well, myxoids tend not to have the epithelial proliferation. This is an example of a higher grade. These are hypercellular stump with bland stromal cells. They have these otherwise really in the like non-discrete cells, almost like stromal sarcoma in the breast, in the uterus, low-grade stromal sarcoma. This is a phalloides pattern. And as I said, I don't have the one with the round cells. So as you all decided, I also favored that this was a giant multilocular cystadenoma of the prostate for the reason that I mentioned. I didn't think this was coming from the seminal vesicle. I did not think that this was a stump of the prostate for the reason I thought that the stroma just did not match the features of this typical of stump in the prostate. So I thought that this was a possibility. I also left an option for the surgeon that I couldn't completely rule out that this is cystic degeneration of BPH, because oftentimes there is, when BPH is so expanded, there may be like a median lobe that forms, and this could have been like an exaggerated median lobe that started to enwrap the seminal vesicles. But in any event, I did think there was a benign lesion. And so a few words on these giant multilocular cystadenoma of the prostate. They are extremely rare, benign, fewer than 30 cases reported. They're typically located along the midline, and that's why I was also thinking, could this be like a median lobe of a cystic BPH, possibly? Anyway, they may occur at any age from 23 to 80 years. Our patient was 71. Presenting symptoms are similar to BPH, and they have this mass enlargement that may cause abdominal distension and GI symptoms. And imaging show a large retroperitoneal multilocular mass compressing adjacent organs, especially the bladder and the rectum. Treatment is basically excision, and adherence to surrounding structure may make complete resection difficult and then elicit this clinical suspicions malignancy. And I think this is it. And please, I would solicit you to do the evaluations. And I think we have about more than 5 minutes, 7 or 8 minutes to discuss for you if you have questions. Thank you so much for coming. No, I had this case about 2 months ago, and I know given that this was invasive, the patient was underwent BCG because he was hyperplasia, so I was treated, and it was superficial invasion. Most of the tumor was low grade, so it was treated with BCG. Other than that, I don't know.
You mentioned the under recognition of variant histology and especially lymphoepithelioma. Like, do you kind of counsel the clinicians on that? I've had them ask me, like, what does that mean? And I'm hesitant to say that it's favorable because there's not a lot of data, but it does seem like it's favorable what there is.
Yes, yes. So if it is lymphoepithelial-like, although I have very few cases, maybe 1 or 2, obviously there are factors. And actually, one case that I actually had, it was mixed with other higher grade variants. But yes, I do put a comment. I honestly think that it is so, the cases are too few in the literature. Although, as you mentioned, some suggested that lymphoepithelial-like is one of the lower grade variants that do better than others, but this is not completely established in the literature. I just said that in my comment, yes. And in the case that it was mixed,
flowering membrane nest. The third promoter mutation is going to be helpful. I'm just wondering, let's say the flowering membrane nest is divided by Rosacea carcinoma in situ. In this situation, it's curious, third promoter mutation is going to be helpful as well.
So you're saying that if there is urothelial carcinoma in situ involving Long's nest,
Yeah.
dirt should be positive.
Positive. So in this,
Mutation should be positive.
but the next day the Rosacea carcinoma should be positive too, right?
Correct.
So
But
how
the
can-
difference, yes, difference is really morphologic because nested urothelial carcinoma looks benign, psychologically benign, whereas urothelial carcinoma in situ involving Long's nest should look like urothelial carcinoma in situ. So I would expect hyperchromasia, pleomorphism, this cohesion of the cells, all those malignant features. So the challenge with nested urothelial carcinoma is that it looks benign, whereas urothelial carcinoma in situ does not look benign.
So both third positive. Dr. Williamson, sir, I have a question for the renal case you shared. Actually, I and Dr. Jericho have a few this kind of cases that is really tough because morphologically just look at density, tubular structure, clear cell feature, the actually profile is not inclusive. So I just wondering in this situation, how often do you do molecular testing for the final classification? Except for clear cell renal cell, clear cell pathway, sometimes ELOC and RCC with fibromen alter stroma, especially in the biopsy and the other differential too. I just wonder how often you molecular testing.
If anybody couldn't hear the question, how often do you do molecular testing for those renal tumors that are challenging, clear cell papillary? I think it's tricky. I wish we had a sort of a kidney panel that was a quick, easy next-gen sequencing that had a lot of the kidney cancer-related genes like VHL, or you mentioned ELOC, which is a rare one, but something that's of interest recently. So it's tough for us. We'd have to do a comprehensive gene panel, which is difficult to justify sometimes. So I often don't use sequencing, but if you have something that's sort of in the gray zone, there is some literature that clear cell with keratin 7 positivity is favorable. And so sometimes I've put a note that, like, if it doesn't fit perfectly into any box, if it's not a perfect clear cell papillary tumor, and ELOC is kind of an emerging entity thought to be favorable, but we don't know too much about it right now, and I think it's difficult to find a sequencing panel that includes that unless you do a comprehensive one. I've put a note saying, this is a small clear cell tumor that has keratin 7 positivity. Some studies have suggested these are favorable, and the ELOC mutated is an emerging category. But yeah, so far it's hard for us. I don't know if you have any different experience that you've been able to get the sequencing more often, or.
Yeah, so we have an in-house sequencing panel that does not include, however, it's the FDA-approved panel, which does not include all the genes of interest that may be included in a renal panel. Thank you. So yes, I was saying that we have an in-house FDA-approved gene panel, and I discussed this with our molecular pathologist. Unfortunately, since it's FDA-approved and it's standard, the panel cannot be modified, but not all genes of renal interest are included in the panel. And so they would have to be run separately with FISH. So in the end, I just don't routinely request sequencing, and if I'm interested in a particular lesion, such as MITF, like a TFEB altered or a TFE3 altered tumor, I just do FISH. I don't even request sequencing. But sequencing is typically requested by our oncologist. This is my practice.
Thank you.
Thank you. I have a question for Dr. Williamson. You showed that case of seborrheic keratosis, like HPV lesion, and another HPV. I had a similar case a few months ago. The urologist took the biopsy from the foreskin, and another one from the glans penis. And he said, viral wart. And the one from the foreskin looked very much like a seborrheic keratosis, like the one you showed, with pigmented basal cells. And the one from the glans penis looks like a viral wart or penile wart. And I did P16, and both were positive. And I just sort of said, my conclusion was, because this one was from the proper skin, there's no reason why he can't have a seborrheic keratosis from the foreskin, whereas then the one from the glans penis was a viral wart. So, because I was thinking in the female genital tract, you can still have seborrheic keratosis as a condition and viral wart as a condition. Could you just clarify that for us?
Yeah. I mean, I think it's interesting. It's a gray area. Whether some of these are true seborrheic keratosis. In our study that we have in progress, there were some where the clinician said the seborrheic keratosis was the favored clinical impression. So I guess it probably does sometimes happen, and we had some that were HPV negative. At the same time, I also kind of interpreted that since some of the patients had both what looked like a classic condyloma or wart and the seborrheic keratosis-like lesion, that was an argument that maybe they both are HPV related, since they have both kind of morphologies in the same patient, or in other words, some of the same patients had classic warts as well. But I think as long as you've got the one that is that looks like a wart, then it probably doesn't matter as much what you do with the other one. But yeah, at least in our study, there were some that the clinicians did think were actual seborrheic keratoses, so maybe it does happen as well. Well, thanks a lot for joining us.